topic is very interesting. Basics of ECG interpretation. The thing is, this is the most common investigation what we see as far as cardiology is concerned. And if you look at the history, the ECG is one of the most oldest investigation which has been there for the last 100 years, and still it is continuing to be most important investigation for the cardiologist. William Einthoven was the first person who has discovered electrocardiogram, and for this he was given a Nobel Prize also. Now, before understanding the ECG, everybody should understand the first conduction system. The ECG conduction starts from the SA node. From there, the conduction will spread, action potential will spread to the AV node. From AV node, it will go into the Purkinje fibers. And like this, from there, it will go to the bundle of branch, and this cycle will complete the action potential spread towards the atrium to the ventricle. So how does this ECG actually work? The electrical impulse wave of depolarization, which will be picked by the electrodes which are placed on the chest, it will generate the particular action potential, and the voltage change is sensed by the measuring the current change across the two electrodes. One is a positive, another is negative. Generally, this electrical impulse, they travel in particular direction. They always travel towards the positive electrodes, and because of that, we will see the deflection, which is a positive deflection in the ECG. But suppose if the same thing will travel away from the positive, means if they travel towards the negative side, then the negative deflection which will be there on the ECG. So here, if you see, suppose action potential is traveling towards the alphabet 1, then which is the positive side. Here the deflection will be there, which is a positive. At the same time, if towards the 5, which is a minus side, then entire deflection will be in the negative deflection. As a nursing care provider, generally everybody should understand that ECG will be read properly if it is taken properly. The thing is, here the electrode placement is very important. Total 6 chest electrodes are there. Generally we call them V1 to V6. And apart from that, there are 4 limb electrodes, which we kept on the 4 extremities. Here you should remember one thing. The right leg electrode is always a neutral electrode, or you can call it as a dummy electrode. And for the chest electrode, generally we have been using the same nomenclature V1 to V6. The V1 electrode, generally it should be placed at the 4th intercrucial space around the right sternal edge. V2 will be in the same space, but it should be on the left sternal edge. Now coming to the V3 and V4, generally V4 will be always over the apex, and if you want to place V3, you should see that it should be on the way between V2 and V4. This is the location of V3. Now coming to V5 and V6, generally it will be a little bit away from the apex, but it will be on the anterior and mid-axillary line on the chest. If you look at the types of the leads, generally coronal plane and transverse planes are used. If you are thinking about coronal planes, generally lead 1, lead 2, and lead 3, which are called as the bipolar leads. And if you see about the augmented leads are mostly called unipolar, which will be like left, right, and foot. So these are the common leads which are used to get one proper ECG. Now, how these electrodes, with the help of these 9 electrodes, we are forming almost 12 leads. So lead 1 is formed using the right arm electrode, which generally indicated as the red color, and as the negative electrode, and the left arm, which will be always most of the time positive. Now coming to the axis, the normal ECG lies between 0 to plus 90, or precisely if you want to tell, minus 30 to plus 90. This is the normal axis of the ECG. Now the limb leads, they generally look at the heart in most of the time coronal planes. So here, by looking at the leads, you can say that what kind of which surface of the heart is visible on the ECG. So AVL 1 and 2, generally they can tell about the changes which happens on the lateral wall of the heart, while the 2, 3 and AVF, which always gives the information about the inferior part of the heart. AVR, most of the time, it is the right side of the heart. So each lead can be thought of as looking at an area of the myocardium. Here, if you again look about the chest leads, which is V1 to V6, generally they both V1 and V2, they look at the anterior of the heart and the ventricle, while V3 and V4 always tells about the septum. V5 and V6 always tell about the lateral border, or you can say left ventricle. So let's see how the ECG paper looks like. Here, if you see, ECG paper is made up of small boxes and large boxes. If you talk about the small boxes or large boxes, the almost 6 large boxes will make 1 second. And if you look at the parts, or maybe you can say the segments of the ECG, it should be divided into the waves and into the segments. Along with this wave and segment, there are few intervals which are very important. We will see all these things one by one. Now look at the paper, how it is measured. So the small box, which is equivalent to 0.4 second, if you tell about the timings. But if you tell about the height means voltage, then it will be a small box is equal to 0.1 millivolt. So if approximately, if you are talking about entire one large box, which is composed of 5 small boxes, means you are discussing about 0.20 seconds of total duration. This ECG generally contains almost 5 waves: P wave, Q wave, R wave, S wave, and T waves. Apart from that, there are few intervals and segments. We'll come to that one by one. Now, whenever you start interpreting the ECG, the few things which you need to see, that is the first, you check labeling. Labeling can be different as per the hospital policy, but it should definitely contain the patient name. Not date of birth is not mandatory, but if patient's age is mentioned, it should be good. Apart from that, sometimes we write with the pen, like particularly if the particular ECG has been taken immediately after the PTCA, or so this kind of small medical history, sometimes it will be visible on the ECG paper. That we have to remember. Apart from that, once you check the labeling, come and check for the calibration. Calibration, how to check the calibration? Normally, if you want to check the calibration, always look at the angle of the ECG paper, where exactly the ECG strip starts. There you will find one rectangular. This rectangular generally will be of height of almost 10 millimeter. So it will comprise minimum of 2 boxes. So now, if you see that your ECG should not have any calibration issue, it should start with one small rectangular box, which should compose of 2 major boxes. And this tells about the paper speed, which should last for 1 second. The 20 mm paper will be passed. So most of the ECG papers, they will have the similar calibration. Height of the box means 10 mm is equal to 1 millivolt, and the paper will be run with the speed of 20 millimeter per second. So now, after checking the calibration, what you need to look for? First of all, check whether these lymph leads are set up correctly or not. The chest leads are set up correctly or not. Is there any presence of any artifact on the ECG paper? So first, if you want to check the lymph leads, always remember one thing. This is the golden rule. The QRS complex, in this QRS, in the ECG paper, you look at the QRS complex, AVR will always have the negative inflection, while in the lead one, it will be always positive. And if you really want to check chest leads, you always look for the R wave progression. Normally, the R wave will be very small in the V1, and as it progresses to the V6, the R wave size will go up. So R wave progression is a very important parameters to check whether chest leads are placed correct or not. Now, coming to the rate, if the heart rate is regular, you should always check the total heart rate in 1 minute. To decide about it, we have many methods, particularly large square method, at the same time small square method also. If you want to look at the rate, you can divide the respiratory rate with the help of 300, and the number which will tell about the 1 minute heart rate. Here I have mentioned about three major methods which we are using generally. First is the large square method. Whenever you discuss ECG, you should calculate the R to R distance. Here is in the screen, it is visible. You can see almost 1, 2, 3, 4, and 5 big square between 2R. Here the regular rhythm is there. That's why I will directly divide this 5 plus 0.4. 5.4 big square, it 300 divided by 5.4, which will come around 55. So here the heart rate is 56. And if you really want to divide with the small square, you should always use the 1500 number. So whenever you count small square, you have to divide like this. 1500 divided by 27 is equal to 55.6. So again, here also the heart rate is around 56. So this was about the heart rate. Now coming to the rhythm. Rhythm, generally cardiac impulse originates from the sinus nodes. And that's why every QRS must be preceded by the P wave. But this is not the rule. Sometimes a clinical scenario like a second degree block and all, where you will find the P wave, but maybe you will miss QRS complex at certain point of time. So in general, all the QRS complex, generally it will come after the P wave, except in a few clinical scenario like AV block. So looking at the rhythm, here if you see, how do you know that if the heart is in the sinus rhythm or not? So always look for the SA node rhythm. So SA node is in the, generally if you divide the heart into 4 chamber, it will come from the right atrium, and normally impulse will spread from the right atrium towards the downward, forward, and at the last end to the left. That's why if you want to see that whether this ECG is in the sinus rhythm or not, look for these things. P waves should be upright in the lead 2. Remember always, P waves should be inverted always in AVR. So if you want to decide whether this ECG is in sinus rhythm or not, always see these two leads, lead 2 and lead AVR. Lead 2 should have always upright, means positive deflection, and lead AVR should have a negative deflection of P wave. Most of the time, this P waves should look similarly. Arrhythmia, which you call sinus arrhythmia, in that sometimes the morphology of P wave can be changed. Now, what is the rhythm? So here in this ECG, if you see, as per the rule, we will look at the two things. One is the lead 2. Here the P wave is in the positive deflection, while AVR is in the negative deflection. So this ECG is in the sinus rhythm. So now again look at the second ECG. Here again if I see, lead 2 is having a negative deflection. So the P wave is not having a positive deflection. At the same time, if I look at the AVR, again in AVR, it is having the positive deflection. So definitely this ECG is not into the sinus rhythm. This rhythm is atrial rhythm. Now, let's see another one ECG. Here again, if you see in the lead 2, ECG is showing P wave positive deflection, while in the AVR, the P wave changes as if you can see in the lead 2, first 2, 3, 4, almost 4 contraction, it is showing the P wave in the positive deflection, but later on this morphology is changed. So if the P wave morphology is not continuous, means again this cannot be the sinus rhythm. So here the partially the ECG is in the sinus rhythm, again it is not maintaining the sinus rhythm at all. Now coming to the cardiac axis. The cardiac axis represents the sum of the depolarization vector generated by the individual cardiac myocytes. Since the left ventricle makes up the most of the heart muscle under the normal circumstances, the normal cardiac axis is directed down. Again, as I told in my previous slide, the normal axis means it tells about the QRS axis, and it should be always between -30 to +90. So when do you call the axis is deviated or whether the axis is abnormal? So whenever you see that axis is less than -30 or +90, in that range, the abnormal axis can be predicted. So the type of abnormal axis are left axis deviation, right axis deviation, and extreme axis deviation. Here, if it is between -90 to +180, then it should be considered as an extreme axis deviation. How to decide whether the deviation is there or not? So always you can use this method of 4 quadrant. In this, The first quadrant you say is a green quadrant, which from lead 1 to lead AVF. This deviation, normally if overall QRS complex deviation comes into this green zone, you can say that this is a normal axis. But if the normal axis comes into the blue part, then this should be considered as the right axis, while the red color will tell about the extreme axis deviation. We'll go into detail about axis deviation, but before that, you should see particularly the positive or negative deflection, and you have to decide from the lead 1 to lead AVF. How to decide? You should see the QRS complex in each lead and determine what is the cumulative deflection. Here, if you see the QRS, Q, which is a negative, R is a positive, S is a negative. But here the positive portion is more than the negative portion. So the overall total is net positive charge. If some ECG where QRS complex almost both the sides are equal, then we call this as a equiphasic. While in a few ECG, you will see that QRS complex, the majority of the part is in the negative deflection. So this should be considered as a negative. So a positive QRS in a lead 1, it will put the axis in the roughly in the same direction as lead 1. While positive QRS in lead AVF, generally it will go into the lead AVF. So if you combine both colored areas, then you can see the quadrant of the overlap, it determines the axis. As I told in the previous chart, now we'll come to the colorful presentation. Look at here. In lead 1, this is a positive charge. So we are putting in the plus minus 90 to plus 90 because it's a lead 1. But if you talk about the AVF will come always in the downward side. So here, if you combine both these things, the axis will come and corresponds to the blue area, which is a normal axis, which you can consider 0 to 90. But ideally, even if it is minus 30 to plus 90, it should be considered a normal axis. Why it is so very important to know about the axis? Because if you know that there is an axis deviation, you can anticipate few pathologies. Suppose if it is a left axis deviation, what is your anticipation? There can be a ventricular tachycardia, there can be an inferior MI, there can be a left ventricular hypertrophy in most of the scenario, and left anterior hemiblock. If there is a right axis deviation, there can be a right ventricular hypertrophy or anterolateral MI. At the same time, it is also possible in a scenario where left posterior hemiblock is present. Okay, there is one entity which is called Wolff-Parkinson-White syndrome. In this, you can see either left or sometimes left and right both axis deviation in one ECG. Let's see the P wave. These are the segment of the ECG. We will go one by one different waves and segment and interval. So first, talking about the P wave is the first positive deflection on the ECG paper, and it represents the atrial depolarization. Remember the duration. P wave duration is always less than 0.12 seconds. Means if you want to calculate or if you want to remember by the small square, remember it should be always less than 3 small square. If it is a larger than 3 small square, it is abnormal. P wave should be upright in lead 1, lead 2, and inverted in AVR. Already in my previous slide, I told about lead 2 and AVR. If you remember these two things, the P wave direction, in which direction should be, you can decide about the whether rhythm is sinus or not. Atrial abnormalities are most easily seen in the inferior leads like A2, 3, and AVF, and lead V1, as the P waves are the most prominent in these particular leads. Okay, if you look at the different P morphology, you can see here in the lead 2, if P wave looks like upright deflection, at the same time in the lead 6, lead V1, lead 6, here you will see positive and negative both. In the sinus rhythm, the P waves upright always will be there in lead 2, while it will be always inverted in AVR. If you want to really check the size, shape, and always check whether it is followed by QRS complex or not. If the P wave is not followed by QRS complex, there is a high possibility that this patient can have AV block. Now coming to the PR interval. Remember here again how it is calculated from the start of the P wave till the start of the QRS complex, which will be considered as a PR interval. So as per the physiology is concerned, it tells about the atrial depolarization, at the same time contraction. So the normal range, it tells it is about 120 to 200 milliseconds, which will be roughly about 3 to 5 small squares. So if you find that PR is more than 5 small square, you should think about AV block. And if you find that PR is less than 3 small square, there can be a possibility of pre-excitation where your ventricular contraction starts a little bit earlier. Now look at this ECG. Here we have just magnified the one waveform. If you see, P wave starts here and there are almost 1, 2, 3, 4. More than 4 small squares are there. Means definitely it is more than 120 milliseconds. And that's why this is a little bit abnormal. So if it is less than big square, the PR interval is not prolonged. But if it is more than that, then it should be considered as a prolonged. Now here, as I told, 1, 2, 3, 4, 5, 6, almost 5 and little bit more than that. So we can say about more than 5.5 small square, which comes roughly around 220 milliseconds. So this ECG tells about the first degree heart block. So here you can see in all the leads, P wave and QRS complex has some distance, which will be almost more than 1 small square. Okay, coming to the QRS complex. QRS complex will be considered from the starting of the Q till the end of the S wave. So it tells about the ventricular depolarizations. What do you look for? Normally, you should see whether it is narrow or wide. So if it is more than 3 square, you can consider it as a wide QRS complex. If it is a less than 3 small square, means it is a narrow QRS complex. And the shape also you should see whether the Q wave is present in that particular lead or not. Mostly when you put the chest leads from the V1 to V6, in the initial V1 and V2, you cannot see the Q wave clearly, but as you go towards the V6, the Q wave will be prominent. So why is it important to note that QRS complex is narrow or wide? So normally, if it is a narrow QRS complex, then you can understand that this ventricular conduction is normal. So mostly the conduction pathway will be like this: AV node to bundle of his, from there bundle branches, and from there it will go to the Purkinje fiber. But suppose if QRS complex is wide, then it can tell us about the abnormal ventricular conduction. A wide QRS complex will cause the ST segment and T changes also. So sometimes some wide QRS complex rhythm disturbance will confuse us with the MI. So what is the significance of this QRS height? So the tall QRS complex means always you should see that it takes a lot of time for action potential to travel through the ventricular muscles. And that's why it can tell us about the ventricular hypertrophy. So the QRS width is also very important. It should be, as I told, it should be always less than 3 small square. But if it is wider than this, it also suggests the ventricular conduction problem. As I told earlier, it can tell us about the RBBV or LBBV. So coming to one by one, LBB and RBB, left bundle branch block, it has a particular characteristic. If you see, if left bundle branch block is present, the QRS complex may look like a W in V1. Remember this one thing: W in V1 and M pattern in V6. This is a golden rule which will be applicable to find out whether the ECG is having LBBV pattern or not. And if it is a new onset LBBV, you should always consider myocardial infarction. And here, because of this thing, sometimes it is not possible to interpret the ST segment properly. Coming to RBBV, here it is a little bit opposite. So M in a V1 and W in V6, you observe this pattern, and then you can see that this is a RBBV pattern. Now, if you want to remember this as a mnemonic, you can remember with one word: William Marrow. So whenever you think about the left bundle branch block, you should think about it starts from V1 W pattern. And if it is a right bundle branch block, V1 will have a M pattern. So this is a simple and easy way to remember whether bundle branch block is present or not. And always remember this mnemonic, it will help you to read ECG a little bit faster. So now, how we can see that this QRS complex changes as it goes from V1 to V3, V6. So as I told, whenever the conduction starts, V1 will not have clear-cut Q wave, but at its progress, you will see that the height of the QRS complex is increasing. At V4, it it generally becomes equal. The positive and negative deflection becomes almost equal. So sometimes we can see the abnormal Q waves. So when do you say that Q wave is really abnormal? So if you want to label it as pathological Q wave, it should fulfill few criteria. First, it should be at least of more than 40 milliseconds, means more than 1 small square diameter. And at the same time, it should be more than 2 small square deeper. These are the first two criteria. Apart from that, it should be more than 25% of the height of the following QRF. Then only you will say that this is the abnormal Q wave. And at the same time, it should definitely present in V1 to V3. So basically, the Q waves are abnormal if they are very big. And most commonly, it happens because of the previous myocardial infarction, or you can say evolved MI. So permanent, and it is mostly permanent, so cannot tell about the age of the infarction. So in this ECG, if I say, okay, let's see the Q wave depth. Here also, it is not crossing more than 1 small square, not more than 1 small square. Here in a, if you see V1 to V3, no, we cannot see more than 1 small square. So here there is no abnormal Q wave. So this is normal ECG wave, ECG. And if you see this kind of Q wave, where it is significantly deep, which crosses almost 10 small squares. So this wide and deep Q wave in the inferior lead, particularly in 2, 3, and AVF. So this tells about the maybe the RCA, right coronary artery, might have some issue, and patient might have already suffered from the myocardial infarction or maybe inferior MI. Now coming to the R wave progression, how it progressed from V1 to V6. As I told earlier, initially R wave positive deflection will be very less, then V2 little bit more, V3 again it will be more. By the time it reached to V4, the R wave positive deflection will be more than a negative deflection of S. So ventricles depolarize down and towards the left. That's why you will always see right-sided leads means V1 will have a negative, while left-sided leads V6 have a positive. So here when R is more than S, this is labeled as a transitional position. Generally, it happens at the level of V3 or at the level of V4. So abnormal R wave progression, when we say the poor R wave progression, which is a very well-known entity in the anterior wall MI. Now, further, physiology-wise, if you see the no electrical activity happens when ventricles are depolarized. So that's why you should always see ST segment elevation is there or not, depression is there or not, or whether the shape is perfect or not. The ischemia can cause ST elevation or depression, and it may also causes the because of the pericarditis, because of LVBB, or because of benign early repolarization, LVH or LV aneurysm. Now, coming to the next slide. So ST elevation generally will look like this. You can say that spine of cat, ST elevation from in lead V1, lead AVL here also, and lead V1 to V6 are very prominent. So this is the typical ECG of myocardial infarction. Now, ST elevation again you can see in this ECG also from V1 to V4. V1 has the ST elevation. Here almost ST elevation is there by almost 2 small square. Here also. So not that this is because of not MI, but here in this condition, this is because of the LBBB. Now coming to the T waves. So T waves, why it occurs on the ECG? Because of the ventricular repolarization. Anything that disrupts the depolarization, it usually affects the repolarization. So abnormal T waves are possible in ischemia, particularly even in a bundle branch block and ventricular hypertrophy also, it is more evident. Now, you should see whether T wave is upright or inverted. So usually inverted in V1 and AVR, it is a common phenomena. Occasionally, sometime you will see the T inversion will be visible in V2 also, and inferior leads of V2, 3, and AVF, which is generally non-specific. What do you call the T wave? Why? When do you call the T wave is really abnormal? Here, when you see that significant T wave inversion, you can see here, and here also from V1 to V6, you can see that it is a T inversion in almost all the chest leads. QT interval, normally it starts from the QRS complex until it ends at the T wave. And there is one entity corrected QT interval. Here you should calculate between the whatever milliseconds are there, that you have to put in the RI interval, and the formula of QT corrected QT interval is QT divided by under root RI interval in the seconds. So if it is more than 440 milliseconds, then it is considered as a prolonged. This is for the gender of male. And if it is more than 460 milliseconds in a female patients, you should consider that QT is prolonged. Now, again, in this ECG, if somebody tells you to look at the QT interval, you can see almost 1, 2, 3, measure 3 small, almost more than 3 large squares, and it roughly comes about 16 small squares. So here the QT is almost 640 milliseconds, which is definitely considered as a prolonged QT. Now, this is a normal ECG which tells about all the leads starting from 1, 2, and 3 leads. Apart from that, there will be one separate lead 2, where you can see and can count the RR interval and regularity. And if there is a normal ECG, while reading the normal ECG, you should always decide that how to put in the sequence all the waves and intervals. First of all, you should tell about the rhythm, which is a sinus rate, which can be between 50 to 100. Axis generally it falls between -30 to +90. Intervals, particularly we are interested in PR interval, which should be between 3 to 5 small square, and QRS less than 0.12 seconds. Coming to next slide. Now we'll just look at the few abnormal ECGs. Okay, this is the most common ECG we can see on the ECG screening in the ICUs, particularly if patient is in the cardiac ICU. Ectopic beats. Though patient might be having a significant stable hemodynamics, but many patients can have this kind of abnormal ECGs. By looking at these ABGs, somebody at the bedside should not get panic, but at least look for the electrolyte abnormalities. Many times, by correcting the dyselectrolemia, this kind of PVCs will get corrected. These are called ectopic beats, and here the morphology will keep changing. Now, if you want to go for the AV block, there are certain degrees of block: first degree, second degree, and third degree. And in that second degree also there are variation, type 1 and type 2. Just remember one thing: if it is a first degree block, the PR interval will be always constant. If it is a second degree block, here PR interval will be widened, but at the same time one QRS will be dropped. And if it is a second degree type 2 block, then PR interval will be constant, and suddenly one QRS will be dropped. But if it is a third degree, there will be no correlation between any of the P wave and any of the QRS complexes. So now let's have a look at this abnormality one by one. Okay, coming to the first degree AV block, here the PR interval, you can see in this ECG, the PR which starting from the P, it goes till the starting of the QRS complex. So you can say almost 1, 2, 3, 4, and 5 small squares, which is definitely more than 300 milliseconds. So this is a first degree AV block because the increase in the PR is constant and it is visible in almost all the beats. Now coming to the second ECG, here it's a Mobis 1 block. Why it is a Mobis 1? It is actually degree 2, but in the Mobis 1 block, here you can see that PR prolongation is there, which is increasing in the subsequent beat, and then again it is increasing in the third beat, and in the fourth and the fifth it will be completely disappearance of QRS complex. So here this is the second degree Mobis type 1 block. Now if you see this kind of ECG where you can see the QRS complex is not present in all the beats. There are few places where it is completely missed. But if you look at the ECG carefully, here the PR interval is not increasing progressively, but it is a constant. So 1, 2, and 3 beats is showing the same amount of PR interval, but the fourth beat is not showing any kind of QRS complex. So here the QRS complex has been dropped. So this is a Mobis type 2. But again, it is a form of the second degree AV block only. Now, coming to the complete heart block. Here the complete dissociation is there, which is the dissociation between atrium and ventricle. So this complete AV dissociation means independently you will find a P wave and independently you will find QRS complex. But if you see the correlation between this QRS complex and P wave, you will not have any kind of association. And that's why generally these kind of rates are ventricular rates will be less, while atrium rhythm will be more. So you will find more P waves than QRS complex. So this is the complete heart block. Okay, coming to the next arrhythmia, the atrial flutter. Atrial flutter, it is a narrow complex tachycardia. It is a regular atrial activity, generally more than 300 beats per minute. You will always find that there is a loss of isoelectrical baseline and there will be a sawtooth pattern. This is very identical. Sometimes you will see here almost 2 or 3 serration, or sometimes you can see here almost 4 to 5 serration. So by looking at the ECG, if you find that this is a sawtooth pattern and there is a regular RR interval, you can label it as a atrial flutter. Now, coming to the next arrhythmia, the same ECG, but in a different way. If you can see, this is also atrial flutter. Here the sawtooth baseline pattern is present, but between two QRS complex, you can see multiple large boxes. So definitely there is a bradycardia, but here atrial rhythm is more than 300 beats per minute. And that's why this is a classic case of atrial flutter. Coming to the next slide. Atrial fibrillation. This is also one of the most common rhythm abnormality what we see in the ICU. There can be multiple reasons for that. Hypotension, hypoxia, significant acidosis, or any patient with underlying cardiac abnormality, they will have suddenly atrial fibrillation, particularly patient with CRHD, those who are having dilated heart chambers, they are more prone for going into the atrial fibrillation. This rhythm is known as an irregular rhythm. So you will not find a regularity between two QRS P and QRS. So here absolutely there is no P waves. The absence of isoelectrical baseline and variable ventricular rate, it is the phenomena of atrial fibrillation. The QRS complex usually will be narrow QRS complex, and unless the pre-exciting bundle branch block is there, generally you will find it will be less than 2 small square width. So this is a classic example of atrial fibrillation. Now coming to the next arrhythmia, this is ECG of monomorphic VT. By looking at VT from distance, you can say, yes, this is a wide QRS arrhythmia. And here you can see the regularity. It all beats with the regular distance. And that's why this is called a monomorphic VT. You see the abnormal QRS complex has the same shape. The shape is not changing with all the bits. And this is called regular broad complex tachycardia. And here each QRS is identical. Maybe sometime two QRS complexes will have merged and they will show as a capture bits, but otherwise most of the time this kind of ECG will we consider as a monomorphic VT, and the management of monomorphic VT, again it is a DC shock. Now coming to the polymorphic ventricular tachycardia, this is a very deadly rhythm, and in this polymorphic ventricular tachycardia generally there are multiple ventricular foci with a resultant QRS complex. It varies in amplitude, it varies in the axis, it also varies in the duration. So you will see the completely different morphology of QRS complex. And one of the non-entity which we call as a torsades D pointis, it is a special form of polymorphic VT which can occur because of the QT prolongation, and it is a characteristic morphology in which the QRS complex, they will twist around the one isoelectrical line which can go up and down of the isolation line. So this is the ECG where I can label it as a polymorphic VT also, or precisely I can tell that this ECG is a torsades D pointis. And what is the management of torsades D pointis? It's a magnesium sulfate. Next, this is a very deadly rhythm. This is a ventricular fibrillation. A patient who goes on ventricular fibrillation, most of the time they will be unconscious. They will have loss of cardiac output. The immediate cardiopulmonary resuscitation is really essential. The ECG findings wise, if you see here, you will find irregular deflection, either negative or positive deflection, different amplitude, no identifiable P waves, or here even you can't even here the rate will be always more than 150, and the amplitude decreases with the duration. So this is a classical ECG of ventricular fibrillation. Okay, this is a very known entity. This is a STEMI, ST-elevation myocardial infarction. Again, previously also I showed one ECG. Here you can see the ECG. In the ECG, there is a ST elevation which is there in V2, V3, V4, V5, and V6. All the chest lead has a typical ST elevation, and that's why if you look at the lead 1 and AVL, I can say that from this finding I can say that this is an anterolateral STEMI, and which is an acute MI. Okay, now looking at this ECG, the same ST changes are visible over here. Here the ST elevation is only visible in 2, 3, and AVF. This is the classical of inferior MI. Okay, this is also one kind of arrhythmia, but it is a sinus arrhythmia. So sinus bradycardia, sorry. So sinus rhythm with the resting heart rate less than 60 in adults will be considered as a sinus bradycardia. If you see here, between two QRS complex, 1, 2, 3, 4, 5, 6, 7, 8, almost 8 big squares are there. So here definitely the if you divide 300 divided by 8, it will be less than 60. So this is the sinus bradycardia. Now coming to the sinus arrhythmia, many times we see this kind of ECG where you will find QRS complex, you will find P wave also, but if you decide the distance between two QRS complex will be different. Many times people will debate about this, that because of the irregularity between two QRS complex, different duration is there can be some other rhythm. But though you can see in each cycle, there is a particular, all the segments like Q, R, S, P, and T, everything is there. Then also this is the arrhythmia, and that's why this is called sinus arrhythmia. Sinus tachycardia, here between two RR, hardly you can see 1.5 square. Yes, so definitely here the heart rate is almost 150. So this is a classical ECG of sinus tachycardia. So this was about all the abnormal, most common prevalent ECGs what we see in the ICU practices. Now let's do one thing. Let's solve few ECG. So I'll just show one ECG, and from the audience, if somebody can give the hint, okay, we'll just have a look. First, which one of the following is included under the lethal arrhythmia? So options are atrial fibrillation, premature ventricular contraction, supraventricular tachycardia, and ventricular fibrillation. So any responses? Yes, most of them they given the response is a VF. Yes, all these other three, A, B, and C, generally you will have some time to correct the underlying pathology, maybe dyselectremia correction or any other thing where you can start the cardiac infusion. But in the VF, it is a lethal arrhythmia where you will not have time. You have to start CPR and you have to do the cardioversion. So let's going to the second question. Okay. Now, a 65-year-old man with a history of ischemic heart disease is found unresponsive, and he has no central pulse, and he is making no respiratory effort. And this is his ECG. So anybody can tell what can be the diagnosis in this ECG? Carefully look at the QRS complex morphology. I'm getting responses, monomorphic VT and pulseless VT, VTAC. Yes. So this is a classic ventricular tachycardia, VTAC. So normally in this kind of rhythm, ideally if patient is not having any central pulse, you are supposed to initiate the CPR immediately as per the ACLS protocol. Coming to the next question, a 25-year-old man presents with the collapse which occurred as he was playing a football match, and he has suffered episode of fainting in the past also, and this is his ECG. Any hint? Any abnormal shape you are noticing as far as it is concerned with the QRS complex? Any inputs, audience? You can type yes. One of the audience has identified here delta wave. Very good observation. So if you see here, the starting of P and the starting of QRS complex, that you have to observe very carefully. When you see that QRS complex is getting started very early in a pre-excited form, so pre-excitation. So here again, the WPW syndrome, which is having a very peculiar wave, which is called delta wave, which is present in this ECG. If you see if you magnify this particular ECG, you will find that QRS complex morphology is changed. Here the QRS complex is not starting in the acute angle, but delta wave is present. So this is a classical example of WPW syndrome. Coming to the next question. A 70-year-old lady presents with a collapse, and this is her ECG. Can anybody tell about the findings? So in this ECG, just look at carefully about the P, QRS, and T morphology. Elderly lady just had a history of collapse. Here the age is a classical thing. Here, okay, I'll just answer this question. So if you count the big squares, almost it is a bradycardia. The maybe heart rate is around 54 plus. So this is a classical bradycardia, but the patient age is 72. If it is a prevalent in the younger patient without any history of collapse, the bradycardia can be asymptomatic bradycardia. But in a patient who is having 72-year age with history of collapse, with this kind of bradycardia, sometimes they can have some conduction issue. So this is a case of simple sinus bradycardia. So when you read the ECG, you should always divide like this. First, rate. Rate is a 50 beats per minute, because here almost 6 big squares are there. Rhythm, regular, because here you can see in the lead 2, the P wave is in the positive, lead AVR negative. So if in the 2 and AVR, if you look at this kind of P wave, it is a regular sinus rhythm. Axis, the normal axis, P wave, normal, QRS morphology, definitely narrow, ST and T wave, almost normal, and QTC, normal. So this is a case of sinus bradycardia. Coming to the next question, a 35-year-old male presents with the palpitation. He has been drinking heavily with friends over the last weekend, and this is ECG. Anything here you can see this patient is having a AF. Why? Because you look at the RR interval. If you consider almost 5 to 6 beats, all the RR interval are irregular. And if you monitor closely, you will not find any P wave. So here the P wave actually absent, no P wave seen. And there is a baseline which is fibrillary. So this is a classical case of atrial fibrillation. Thank you. If you have any question, you can ask. Dr. Mithilesh is also here.
Thank you, Dr. Chandresh. It has been a very nice presentation, very comprehensive presentation, right from connection of the leads to the waves and axis, rate, rhythm, including the abnormal rhythms. It is a very nicely presented topic. Another thing I would like to see is that you should all be able to see the rhythm and identify whether it is a life-threatening situation or not, like ventricular tachycardia, ventricular fibrillation, because these are the rhythm where we can do a cardioversion, and in this situation, the patients can be diverted to sinus rhythm. That is one thing. And you have to always try to find out the underlying pathology of the patient, why this is being happening in the patient. Is there any dyselectrolytemia? Is there any post myocardial infarction or something like that? Does the patient need some coronary intervention? So all the ECG has to be seen in the context of the patient's history. So that is very important thing. We should know about the history, and we should know the life-threatening rhythms, and any other rhythms are there, we can raise the alarm, and appropriately they can be dealt with. We'll try to take
formula for the calculation of the rate. As I told, if you can calculate a large square, suppose if it is a 5 or 6 large square, just 300 divided by large square will give you the rate.
Or 1500 divided by
Small squares.
small squares. QTC already Dr. Chandresh has told you to calculate the QTC and then you have to divide it by the square root of the RR interval. So that way, but generally we can get QTC as a surrogate marker in our ECG.
Okay, we'll conclude the session over here. Thank you all.
Thank you all for being with us through all this session. Thank you.